I'm hematologist-oncologist Dr. Tony Talebi. Today we're going to discuss myelodysplastic syndrome, MDS. I have the pleasure of being with Dr. John Burns, Professor of Hematology at the University of Miami and the Section Chief of Hematology-Oncology at the Miami VA. Thank you for being here.
Thank you.
Dr. Burns, what is MDS?
Well, MDS is an abbreviation that stands for myelodysplasia, myelodysplastic syndrome. And as a syndrome typically consists of a grouping of findings that form a constellation that typically represent a specific disorder or a group of disorders. And that is what MDS is, a group of findings, both clinical and laboratory, that define a group of entities that we lump together as the myelodysplastic syndromes.
I see. So you mentioned, what are some lab entities that you would look for?
Well, it's primarily a hematologic disorder, and it generally involves the red cells, the white blood cells, and the platelets, specifically deficiencies of one or the other of the above.
I see. So why is it that over time the body's bone marrow tends to make less and less of the platelets or red blood cells or white blood cells? What happens?
Well, first of all, demographically, this is a disorder of old age. The peak incidence is in the 70s and 80s.
Okay.
And just like an old car, things start to fall apart. There are some exposures and environmental aspects that may contribute to this as well. Also, patients who've received chemotherapy, such as alkylating agents or radiation therapy, are also more disposed to developing a myelodysplastic syndrome. But I think of it primarily as something that happens primarily over time with certain aspects of the hematologic system falling apart or becoming broken.
So would it be almost the congestive heart failure of the bone marrow?
In some ways it might be, yeah.
Okay. What about genes or genetics or chromosomal translocations? How does that play a role in developing MDS?
Well, we recognize several gene alterations as part of MDS. There are some that are associated with a better prognosis, specifically if there are abnormalities of chromosome 20 or the Y chromosome. And there are others that are associated with a bad prognosis, specifically abnormalities of chromosome 7. Abnormalities of chromosome 5, the long arm of chromosome 5, do also form a special subset of myelodysplasia that we'll probably talk about subsequently.
Okay. So how does a patient typically present with MDS? What happens?
Well, most typically it's an older patient. However, there are even genetic disorders, so it can present in infancy. But more often than not, it's an older person in their 60s or 70s or 80s. Typically, there is an abnormality of one of the blood cell lines that leads to the presentation. Perhaps most often that would be an abnormality of the red cells, an anemia. But it might as well also include a low platelet count with some hemostatic or bleeding abnormalities, or it might also involve abnormalities or deficiencies of the white blood cells, and that may involve some disposition to infections. But most often it is anemia.
I see. Now sometimes MDS is actually referred to as a pre-leukemic or smoldering leukemia. Obviously that's very concerning to patients. Why do we call, what does that mean?
Well, there are subsets of myelodysplasia, some of which have a tendency to progress into frank leukemia over time, and others do not. We will be talking about various subsets of myelodysplasia subsequently, and I think we can make that point clearer then.
Okay, great. Now, what is a natural history of MDS if untreated?
Well, again, there are subsets of myelodysplasia, and each has a different natural history. We will be talking perhaps about how we classify or prognosticate about myelodysplasia. And the best subgroup has a survival typically of 100 months or so, whereas the worst subset has a survival typically in the range of 9 months or so. And there are two other subsets between those two, and they each have a different natural history, and the natural history generally involves whether or not they progress.
I see.
So the better prognostic subgroups don't progress, they don't often transform into leukemia, whereas the worst subsets do progress, the condition gets worse without treatment, and it often terminates in leukemia.
I see. So let's talk about the classification. The first one is called the IPSS. Would you please
Correct.
explain what that is and how do you classify patients based on that?
The IPSS is the International Prognostic Scoring System. It looks at three features of the myelodysplasia. One is whether or not 1, 2, or 3 of the 3 bloodlines are involved. The other is whether there are specific chromosomal abnormalities which indicate a favorable or less favorable prognosis. And the third is the number of blasts in the bone marrow, which often are an indicator of the ongoing transformation towards leukemia. Each one of these is given a score. The score is added up, and with that scoring, we generally can subdivide the patients into 4 different groups: good, intermediate prognosis type 2, and bad prognosis.
I see. So with very little information, you can actually tell what the prognosis will be in the coming months.
Well, you can tell what the prognosis is for groups as a whole. Of course, every patient has their own prognosis, which oftentimes has factors, in addition to this, comorbidities that have a bearing as well.
So as far as a patient's concerned, they should ask their physician, what is my IPSS score? That's something you would...
Oh, I think that really gets a little too complicated for patients. I would just advise them to ask, what is the outlook?
Okay.
And I think we can factor in the IPSS score plus other aspects of the patient's well-being.
What about, there's another classification called the FAB classification. What does that mean? How is that different from the IPSS?
Well, it is older than the IPSS. It is based more on morphologic features. There are about 6 entities that are described, and then today we're adding on more and more specific subtypes. For example, we start with refractory anemia. Then the next group is refractory anemia with ring sideroblasts.
But it seems like as far as the patient is concerned, the IPSS is more relative to them in terms of the prognosis.
The IPSS gives numbers. It gives a score. And the score can then be used to put them on a specific prognostic curve. The WHO or FAB classification system also can be used to put patients on a survival curve. But I think today, especially for research purposes, the IPSS is what's more generally used.
I see. Now, aside from just the IPSS score, are there any other signs or symptoms that tell you the MDS is going to be more mild versus more aggressive? Like transfusions or blasts in the peripheral blood?
Yeah. Well, you sort of have to look at the patient as in the total package. You have to factor in, as I mentioned before, comorbidities, whether or not the patient has diabetes or renal insufficiency. The age of the patient, many of these patients present in their 80s. Some are very resilient 80s and some aren't. Certainly, if they have increasing transfusion requirement, that's not a good sign. If the counts are falling over time, as you watch the patient, if things are getting worse, they're probably going to keep getting worse. That's the way I look at it.
I see. Very interesting. What about, you mentioned something about infections, that they're higher risk for infections. Is there anything that can be done to prevent infections?
Yes. Well, my goals are, number one, to keep the patient out of the hospital, because, as you know, the hospital is often a source of difficult infections to treat. I also like to keep ports and lines out of the patient, because they also can be a source of infection. Certainly doing things such as getting the annual flu vaccine and things such as that are important. I don't often put the patient on prophylactic antibiotics unless the patient is, by clinical evidence that, or by their track record, demonstrate that they're having recurrent infectious problems. I don't generally give the patient empiric prophylactic antibiotics, no matter what their white cell count is. Sometimes if the patient is having recurrent infections, we can try to stimulate the white cell count with the various growth factors, but again, that's only in special circumstances.
I see. When would you consider performing a bone marrow biopsy on a patient that you suspect might have MDS?
Right. Well, I perform any procedure when it's going to make a difference in how I manage the patient. So there are some patients with likely MDS who may not get a bone marrow if it really is going to change their management, if they're elderly and they're responsive to, say, erythropoietin administration. I may not. But most patients with myelodysplasia, in order to define their prognosis, and specifically the blast count, and to do the cytogenetics, all of which are part of this prognostic scoring system, and all of which do pertain to the various treatment options that we have, I would say most patients would sooner or later get a bone marrow examination.
I see. And we'll get to the treatment specifically later, but let's say a patient has had low counts, which has led to a bone marrow biopsy, which is ruled in MDS. Generally speaking, what happens next with that patient?
Well, at that point in time, then we do have all the information we need to formulate a prognosis. And then the next job is to discuss what the various options are. And the options would vary according to the patient's performance status, their comorbidities, and most specifically their age. The age is important because for some patients, a bone marrow transplant is a consideration. That is an allogeneic bone marrow transplant, a fairly daunting procedure, and age is a very limiting factor for most patients with myelodysplasia when one talks about bone marrow transplant.
I see. Now, you mentioned the growth factors. What are red blood cell and white blood cell growth factors, and when are they used?
Well, for the red cells, we have the natural erythropoietin that is made in the laboratory now. It's often effective in mild cases of myelodysplasia, in mild cases of refractory anemia, to bring the hemoglobin up to a level that is acceptable for the patient's activities. For the white cells, we have several white cell growth factors, colony stimulating factor and macrophage colony stimulating factor. Both of these are available under various brand names. They do increase the white cell count in some patients. In some patients, I would have some concern that they might accelerate the transition to leukemia, however. We also have growth factors for the platelets. Those are thrombopoietin mimetic agents. And I might just mention that here, again, the concern is that it might enhance the transition to leukemia. So with the growth factors, they can be double-edged swords. They can increase the normal cells, but sometimes they may also stimulate the abnormal cells, so we do want to be cautious.
I see. So if someone has low platelets or low red blood cells, when do you actually consider transfusing them? What?
Well, there are no specific guidelines, but generally it depends on the patient's ability to tolerate anemia and keep them a reasonable quality of life and functionality. For most older patients, we do like to keep the hemoglobin above 8. For some, that number might be 10 if they get cardiac symptomatology. When the hemoglobin goes below 10, then we will try to keep it above 10. But most patients start to become symptomatic somewhere below 8 grams of hemoglobin. For platelets, some patients tolerate a fairly low platelet count with very little manifestations of bleeding. Others, that's not the case. Generally, we get concerned about bleeding complications, generally when the platelet count gets below 20,000. As a rule in the hospital, we often try to keep the platelet count above 10,000, but as most myelodysplastic patients are outpatients, we're not seeing them every day. We might be seeing them twice a week, we might be seeing them once a week. So we have to be a little bit more liberal with platelet counts. If we know that their platelet count today is 20,000, and we're not going to see them for 2 or 3 days, we know that their platelet count is going to continue to fall by their track record, then we'll give them platelet transfusions at that time. However, if they seem to be hanging with a platelet count of 20,000 by their past performance, we might just keep an eye on them.
I see. What if family members ask you, should they be tested genetically if someone's been diagnosed with MDS?
In general, the answer is no, except in the pediatric occurrences, Fanconi's anemia, and there are several genetically linked cases of myelodysplasia. But for the most part, these are acquired abnormalities of chromosomes that occur in only one limited subset of the patient's genetic pool, and it occurs later in life. It is not at all transmissible genetically.
I see. Now, getting back to transfusions, why does a patient's iron level go up if they continue to receive red blood cell transfusions?
Well, each unit of red blood cells has a little over 200 milligrams of iron, and we get concerned when the iron content in the body goes above 10 grams. So that would be 40 units of red blood cells, and many patients with myelodysplasia over their subsequent lifetime, if they're getting 2 units of blood every 3 weeks, they can reach that 40 limit pretty quickly.
And what happens if where does the iron deposit, and why is it bad for you?
Well, the iron deposits in various organs around the body. It can be in the heart, the liver, the pancreas, the joints. In actuality, in most myelodysplastic patients, even though we are accumulating an iron load, it rarely does end up in clinical consequences. Unfortunately, the myelodysplastic syndrome and its consequences often lead to a shortened survival, and the point is that the accumulation of iron in these other organs rarely has an impact on their quality of life or survival. That would be different, though, for some patients presenting in, below the age of 60, say. I don't want to pick a specific age, but there are patients that have quite long survivals. It's a subset of patients who are transfusion dependent for many years. And in these patients, we do want to take into consideration the accumulating iron load and take various measures to try to alleviate that.
I see. So how can one's iron be lowered aside from stopping transfusions?
Well, in the patient with iron overload, most typically the patient with hemochromatosis, the way we do that is by taking blood out. Now, that's obviously not feasible in a patient with myelodysplasia. We have iron chelating agents, desferoxamine, for example. There's both oral forms and intravenous forms of the iron chelating agents that are somewhat effective in offloading iron. It takes iron from the blood, and the patient then, the chelator ties it up, and the iron is excreted into urine.
I see. Is there anything in terms of diet or vitamins that the patient might take to help with their counts?
Well, a good diet in general is obviously very important. You do want to make sure when you're diagnosing the patient that they're not folate or B12 deficient. Some patients have a form of sideroblastic anemia that responds to pyridoxal phosphate, a vitamin.
That's vitamin B6, correct?
B6, correct. We often put the patients on who have a chronic anemia on folic acid, although the evidence that it really helps is limited, but we do want to make sure that they don't become folate deficient. While on that topic, I think it's important to make sure that the patient isn't zinc toxic. There are a number of myelodysplastic patients that have become that way because of ingestion of zinc, which then leads to copper deficiency. The most notorious in recent cases have been associated with the toothpaste that contains zinc, but patients do take zinc supplements for various reasons, and it's something that one has to keep in the back of your mind. You want to make sure the patient with their, you might say, complementary medicine aren't getting exposed to agents such as zinc or other presumed nutrients that might actually be toxic.
I see. I think more than anything, our patients from us want hope. How do you give your patients hope with MDS? Well,
the main thing I do is I don't emphasize the fact that it's free leukemic, because the term leukemia, of course, has a very awesome implication. We do have to be frank with the patient, and especially in the subsets that have a high frequency of transformation into leukemia, it's important for them to know that that does occur in some patients and that may happen, but we don't overemphasize that term. Also, some of the treatments we have today are actually quite effective in delaying the transformation into leukemia, and so we do emphasize the hope that implies that we can delay the transformation if that would be a problem.
Wonderful. Thank you so much. Thank you for watching. We hope this has been educational for you.